It's my honor to invite our next speaker, registrar from Sheffield, Yorkshire. It's Matt Lee, who is, in spite of his young age, has more than 100 publications and a really vast activity with small bowel obstruction, national data, but also have a lot of experience on cardiovascular complications, specifically atrial fibrillation. Thank you for coming and making this talk. Thank you.
Yeah, you can hear me. Morning, everyone. It's really great to be here. I'm going to give you a quick overview of some of the work that we've been doing looking at post-operative atrial fibrillation, which, as I'm sure you'll agree, is the bane of many of our lives. So why is a general surgeon, why is a colorectal surgeon interested in post-op AF? And we've all been there, 2 o'clock in the morning, you've cleared all the admissions off the board, you're thinking, I might just get a nap here, I might be able to get my head down for an hour, and then you get a phone call from the house officer, from the intern on the ward, saying someone who had an operation 3 or 4 days ago has a heart rate of 120. And that's the very beaten look we get. And we all know that once we've ruled out, they're beyond the window for their anastomotic leak, we know we're going to go to that ward and say, well, they're in atrial fibrillation. What should we do? Call the medics, I think, is the usual answer. But this is one of the things that caused me this wound me up quite a bit over a 6-month period. And so I felt I had to disappear down the atrial fibrillation rabbit hole to see whether we could actually get any answers. Atrial fibrillation, this is an ECG showing atrial fibrillation, which is notable because it is 1, irregular, 2, it's common, and 3, it's the only abnormal ECG that surgeons can reliably identify. Good, so we're playing for laughs, that's fine. Now, if you were a cardiac surgeon, you would have a wealth of literature to look at to tell you about how to manage post-operative atrial fibrillation, because they have one organ to look after, and when it goes wrong, that's their priority. For general surgeons, for the GI surgeon, it's a different problem. These 12 papers here represent the sum total of cohort studies that have been done to identify risk factors for atrial fibrillation after surgery. And it represents, I think this was about 5,000 patients in total with data over the last 5 to 10 years. These are bar charts showing the incidence of symptomatic in-hospital atrial fibrillation following surgery. And you can see it's quite varied, and it's been split up into esophagectomy, which is, as you can see, has a rate of about 18 to 20% in-hospital symptomatic AF. There's 2 studies on colectomies, which range from about 8% up to 25%. And then you've got sort of other general surgery, so things like benign biliary procedures, or other sort of more minor things. And when you put all that together and average it out, about 10% of the patients that you look after as a general surgeon will get symptomatic in-hospital atrial fibrillation. These were detected, as I said, they're detected because people had symptomatic episodes, so they had an ECG done as part of a cohort study. No one was going looking for it, it's just, if it's there, it was recorded. So we did some more work on this. There's obviously a difference in the types of operation that are associated with atrial fibrillation, but we weren't quite happy with this idea of in-hospital atrial fibrillation only because we know that patients can come back down the line, further down the line with problems because the atrial fibrillation might not have been detected. And also with where we are, a lot of our patients are looked after in peripheral hospitals where we won't know about it unless they have a major complication. So this is a chart showing the rates of atrial fibrillation within 30 days of surgery and 90 days of surgery. And this is using administrative code, so again, it's only going to be symptomatic data, but it does tell us an interesting story. Particularly if you look over on the far right of the chart, you can see that the 30-day rate of atrial fibrillation for people who've had basically a gastric cancer resection, 30-day rate's about 10%, but you get an extra 5% if you come back and look at them 3 months down the line. Similarly for, I think for small bowel resections, which is an emergency operation, you do get a slight increase if you look out to 90 days. And then some of the other major hepatobiliary resections, you see that as well. And why do people get atrial fibrillation? It's been hinted at. over the last couple of talks. I think we can split it down because we need things to be simple. There's two things. There's the things that are the patient's fault, and there's things that are our fault. Okay? Things that we can do and things that we can't change. In the patients, there's this idea of that there's altered signaling in the myocardium. As you remember, you've got pacemaker cells that send signals through all the wiring in the heart, causing coordinated contractions. There's something happens that disrupts that, and that can be things like electrolyte abnormality, hypokalemia, particularly, or it can be that they've got predisposing conditions, which we'll touch on in a minute. And for surgeons, it's all about the sympathetic drive and inflammation. As we cause more pain, we get more noradrenaline release, you get your increased heart rate, and you'll eventually tip people over into atrial fibrillation. And I've put a picture of someone leaning over a cliff there to remind me to talk about why we think this group of patients get atrial fibrillation. You'll be familiar with diabetes, just to go completely left field. You'll be familiar with diabetes, the idea that over time you build up insulin resistance and you're borderline diabetic, you have glucose intolerance for a while, then one day you just lose that. You're not intolerant anymore, you're full-blown diabetic, you have no control over your sugars. A similar thing happens with the heart. So over time, over your life, you build up sort of an inflammatory change within the endocardium, within the lining of the heart, until one day you have an event, which is an operation that tips you over the edge, and you're in atrial fibrillation, and that's it. So this is it's a symptom of a lifetime of build-up of damage and inflammation. When we look at the patients, and this is based on our data set from Sheffield, about 2,500 patients over the age of 65, there's four things that really matter in the risk of developing atrial fibrillation within 90 days. Being older, which isn't a surprise. Having heart failure, so cardiac failure, is quite strongly associated with atrial fibrillation. Being hypertensive and having peripheral vascular disease, which to the eagle-eyed among you will realize that this is essentially the CHADS-VAS score. So the same score we use for the risk of stroke afterwards will more or less correlates with whether you will get atrial fibrillation after surgery. From our sites, that's things we can't really change, because if the patient's got those conditions, they've got those conditions. For us, as surgeons, what can we do? So we can think about our approach and how we can modify it, and this is again drawn from the prognostic literature. If you do a thoracic operation, you're more likely to get atrial fibrillation, and that's probably because you're operating right next to the heart. If you do things to the pulmonary vessels, you can cause change in signaling and change in the pacemaking. If you do minimally invasive surgery, you're less likely to get atrial fibrillation, or if you're making big cuts, you get more of a sympathetic response and inflammatory response. Down the line, if people develop septic complications, so pneumonia, electrolyte abnormalities, they're all more likely to get atrial fibrillation. And why does it matter? Why does it matter? You've heard hints about the impact on long-term survival already. If we followed our data set of 2,500 patients out as far as we could, they're about twice as likely to die within the follow-up period. It's not disease-specific, it's a mix of cancer and other things, and there's a lot of competing risks. I think that's quite compelling data. And when you look at the literature, your rates of thromboembolic events are 2.5% compared to about 0.5% if you've got atrial fibrillation. Your chance of stroke is 3 to 4 times higher if you've got atrial fibrillation. And again, the literature supports that 2 times risk of mortality. So we should care, because what's the point of putting someone through a big operation where we sweat, make sure we've done a beautiful resection, and then they die because they've got a dodgy heart and we didn't do everything we could to reduce that risk. And this is just to highlight that we don't know what we're doing. So if I was to tell you that you had a 73-year-old woman who'd had an emergency laparotomy for a small bowel obstruction with no resection, you just freed up some adhesions, and she then develops AF in the post-operative setting, we asked surgeons, anaesthetists, the general medics, and the cardiologists what they would do, how they would treat that patient pharmacologically. They tended towards beta blocker, but there were a lot of don't knows and let's use some other fancy drugs. When we said we've got someone who's got a 58-year-old who's got an anastomotic leak after a colorectal cancer, we're going to take him back to theatre, but his heart rate is 130, what should we do? This is what you get, which is a bit more of it looks a bit more like people have thrown darts at a board. We don't quite know what we're doing. And finally, the person who's had, this was someone who'd had a lap cholecystectomy, had been kept in overnight because the theatre list finished late. We just found AF when we did his observations before going home. How are you going to treat this man? And again, we're not quite clear on what we should be doing here. So the upshot of this is it's a common problem. It's associated with bad outcomes, particularly increased risk of mortality. We think there's a high-risk patient group, but we need to prove that. The things that we can do, we can reduce the surgical insult, as has already been said twice this morning, and do our best to prevent severe complications. And obviously, if you've got sepsis driving, that's something you need to treat. But we don't know what the best drug treatment down the line is. And just some thoughts to leave you with. We've said it's high risk, and that's just in the symptomatic population. How many people have atrial fibrillation that we don't know about, where we might be able to improve some of our outcomes further? So should we be screening people at a high-risk group, perhaps? Should we be giving the POISE trial, you've mentioned that, is that the high-risk group? Can we pick out the high-risk group, and that's maybe where beta blockade's helpful? And actually, what should we be doing at 2 o'clock in the morning? How should we be treating these patients? So thank you very much.